Assalamualaikum, and I'm going to present about the introduction of Marfan syndrome. So, what is Marfan syndrome? Marfan syndrome is a genetic disorder of connective tissue. Connective tissue plays an important role in the body because it provides strength, support, and flexibility to bones, blood vessels, and also organs. According to Medline Plus Genetics, Marfan syndrome is caused by a change or mutation in a gene called FBN1. Because this is a genetic condition, it is not contagious and cannot be caught from another person. In terms of how common it is, Marfan syndrome affects about 1 in 5,000 people worldwide. This means that out of every 5,000 individuals, approximately 1 person is expected to have this condition. Although it is considered a rare disorder, it occurs in people of all races and ethnic backgrounds, and it affects both males and females equally. So, how it is inherited? Marfan syndrome is usually inherited in an autosomal dominant pattern. This means that a person only needs one copy of the mutated gene from either parent to develop the disorder. If one parent has Marfan syndrome, then there is a 50% chance that the condition will be passed on to your child. However, Medline Plus Genetics also states that in some cases, Marfan syndrome can occur even when there is no family history. This happens due to a new or spontaneous mutation in the FBN1 gene.
Hello everyone, my name is Nura Anisuba Bedemaizi, and today I will explain about the genetic mechanism of Marfan syndrome. So, first, Marfan syndrome is caused by specific gene which is FBN1 that encoded a protein called fibrillin 1. So, to make it easier to understand, I will first explain about the normal function of FBN1 gene, and then I will explain about what happens when a mutation occurs leading to Marfan syndrome. Normally, the FBN1 gene encoded a protein called fibrillin 1. So, fibrillin 1 is a very essential component of microfibrils in connective tissue. So, these microfibrils provide a structural support and also elasticity, especially in tissue such as aorta, ligament, and also skin. So, in addition to providing structure, fibrillin 1 also play an important regulatory role, which is it helps to bind and sequester transforming growth factor beta in an inactive form, preventing excessive signaling. However, in Marfan syndrome, this normal process will be disrupted due to the mutation in the FBN1 gene that lead to two major mechanisms, which is structural failure mechanism and also TGF-beta dysregulation. So, the first one is structural failure mechanism. So, Marfan syndrome is caused by an autosomal dominant mutation in the FBN1 gene, leading to defective and also the reduced fibrillin 1. And as a result, microfibrils formation is impaired. So it causes the elastic connective tissue to become weak and also fragile. Thus, this structural failure will lead to lens dislocation and also aortic aneurysm and dilation. The second one is transforming growth factor beta dysregulation mechanism. So, in addition to structural weakness, the loss of normal fibrillin 1 also lead to excessive transforming growth factor beta signaling. So, because fibrillin 1 cannot longer effectively bind to the transforming growth factor beta, thus transforming growth factor beta will become overreactive. So, this excessive signaling will result in abnormal tissue growth, degradation of extracellular matrix, and also further weakening of blood vessels.
Diagnosing Marfan syndrome can be challenging because the signs and symptoms vary from person to person. Some individuals show obvious features early in life, while others may not develop a clear signs until adolescence or adulthood. The first step is recognizing the red flags. Doctors look for common features like a tall stature with long limbs, long slender fingers called arachnodactyly, chest deformities, and spinal curvature or scoliosis. Risk factors such as a family history of Marfan syndrome or thoracic aortic aneurysm, as well as new heart or eyes problem, increase suspicion. In children, diagnosis is especially tricky because many signs develop slowly. Once Marfan syndrome is suspected, clinicians use the CHAN criteria. This is a checklist that helps doctors to distinguish Marfan syndrome from other connective tissue disorder. Major features include aortic root dilation, lens dislocation, dural ataxia, multiple skeletal problems, or a positive family history. Minor features include stretch marks, loose joints, a long thin face, and a high arched palate. Next, targeted investigations are performed. An echocardiogram checks the aortic root and heart wave, which is vital because cardiovascular problems are the most serious risk. A slit lamp exam evaluates lens dislocation in the eyes. MRI imaging is important to assess the aorta and spine and detect dural ataxia. Additional imaging like CT scan or chest X-ray may also be used if needed. Genetic testing plays a key role in confirming the diagnosis, especially in borderline cases or for family screening. Marfan syndrome is caused by mutation in the FBN1 gene, which encodes fibrillin-1, a protein essential for the strength and elasticity of connective tissue. A blood-based genetic test can identify pathogenic FBN1 mutation in the majority of affected individuals. While a positive result strongly supports the diagnosis and allows testing of family members, a negative result does not completely exclude Marfan syndrome, as not all mutations are detectable. Genetic confirmation is particularly valuable when physical findings are incomplete or when early diagnosis is needed for preventive management. Finally, the diagnosis is confirmed by integrating clinical findings, imaging results, and genetic testing using CHAN criteria. Marfan syndrome is diagnosed when sufficient systemic features are present together with either a positive family history or a confirmed FBN1 mutation. If these criteria are not met, alternative connective tissue disorder are considered. This systemic, stepwise approach ensures accurate diagnosis and allows early monitoring and treatment to prevent serious cardiovascular complications.
Hello everyone, my name is Muhammad Yusnizam bin Yusuf. Today, I will talk about Marfan syndrome symptoms. Marfan syndrome is a genetic disorder that affects the body's connective tissue, which plays an important role in supporting organs, bones, and blood vessels. Marfan syndrome can affect many different systems because connective tissue is found throughout the body. One of the most noticeable features is related to the skeletal system. People with Marfan syndrome are often tall and slender, with long arms, legs, fingers, and toes. They may also have joint hypermobility, flat feet, and a curved spine known as scoliosis. Some individuals have a chest that appears sunken or protruding, which can affect posture and breathing. The cardiovascular system is the most serious area affected. Symptoms may include an irregular heartbeat, heart murmur, and problems with heart valves. Many patients experience enlargement of the aorta, the main artery carrying blood from the heart. If left untreated, this can lead to the life-threatening complications such as aortic dissection. Marfan syndrome also affects the eyes. Common symptoms include blurred vision, severe short-sightedness, and dislocation of the eye lens known as ectopia lentis. These eye problems may worsen over time if not treated. In addition, some individuals experience respiratory issues, such as shortness of breath or a collapsed lung. Other symptoms include chronic back pain, stretch marks on the skin not related to the weight change, and frequent fatigue. Because symptoms vary widely between individuals, early diagnosis, regular monitoring, and proper medical care are essential for improving quality of life and preventing complications.
Assalamualaikum and hi, my name is Putri Nur Syahinda binti Mansur. I will be explaining about the management and intervention of Marfan syndrome. Beta blocker therapy is used in Marfan syndrome to reduce stress on the iota. It was first suggested in 1971 and is often studied early in life. By slowing heart rate and reducing force of contraction, beta blocker can slow aortic enlargement and protect weakened aortic tissue. They have been shown to improve aortic stiffness and elasticity in patients with mild to moderate dilation but not in those with severe dilation. ACE inhibitors and some negative inotropic calcium channel blockers have also been studied for Marfan syndrome. In one trial, ACE inhibitors appear to slow aortic enlargement and reduce adverse events over 3 years compared with beta blockers. However, this may reflect selection bias because lower risk patients were more likely to be given ACE inhibitors while higher risk patients were treated with beta blocker as standard care. Other studies have shown mixed effect with limited impact on aortic compliance and little change in the ascending aorta. The second major treatment for Marfan syndrome is heart surgery. Its main goal is to prevent aortic dissection or rupture and to correct valve problem. Common procedures include aortic valve repair or replacement, ascending aortic aneurysm repair, and mitral valve repair or replacement. Some patients may undergo thoracic endovascular aortic repair. Lastly, for the future treatment is focused on gene therapy. CRISPR-Cas9 is a gene editing tool that is a part of gene therapy for treating Marfan syndrome by induced DNA Cas at specific site. CRISPR-Cas9 is broadly used because of its high efficiency and accuracy, facilitating gene function studies, disease modeling, and therapeutic strategy exploration. It is specially designed to guide single-guided ARNA to direct the Cas9 enzyme to specific DNA sequence and then cut the DNA which allows the gene to be added, removed, or replaced. CRISPR-Cas9 system successfully repair the FBN1 pathogenic locus in Marfan syndrome patient cell. CRISPR-Cas9 corrected mutation in human IP axis without affecting stem cell properties, supporting its potential for Marfan syndrome gene therapy.